Daily chest pain, but it's not a heart attack. It's called angina. We show you how a tiny device, small enough to hold between your fingers, could change how doctors treat this condition. Good morning, I'm Alexis Del Cid. Welcome back to All Things Heart. Today we're talking about what could be a new approach to treating angina. Angina is caused by reduced blood flow to the heart, and often that is caused by coronary artery disease. It can bring intense chest pain, which can then spread down to your arms, your shoulders, your neck, and statistics show nearly 11 million people in the U.S. suffer from angina. Currently, it's treated with lifestyle changes and medication. But now there's a clinical trial involving this device. It's a small tube shaped like an hourglass implanted into the main vessel that collects blood once it leaves your heart. The goal is to create pressure that then increases blood flow to areas of the heart. So to dive deeper into this topic, we are so happy to welcome interventional cardiologist Dr. Prasad Gunasekaran, who's leading this trial, and we also have Ankita Tiwari. Ankita is a clinical research coordinator. Thank you both for being here.
Happy to be here.
And we are also thrilled to be joined by our patient, Ann Weishaar, from her home in Atchison. Ann is taking part in the trial. Good morning, Ann.
Good morning.
How are you feeling?
Oh, good.
And when did you get the device?
It was in January, I think.
Okay, so just a few months ago. Now, Dr. Gunasekaran,
Sure.
when someone has angina, what's happening in the body to cause that pain?
So, long story short, the lack of oxygen to the muscles in your heart is typically what translates into a symptom called angina. But often this presents as chest pressure or tightness, or pain in your jaw or your shoulders and other things. But the core principle is that your heart muscle and its fuel, which is oxygenated blood, is lacking in these situations, and that's what leads to angina.
And Ann, you lived with this pain for decades. This began in the early 2000s. How often were you in pain, and how did it affect your daily life?
Well, it got worse later, and probably within the last year and a half, it was really intense and bothered me a lot.
And where would you feel the pain most?
I suppose in the heart region, but it was more of a feeling. It was intense pain and got worse and worse. And of course, I'd eat antacids until they went out of style, but it didn't help. So then I had to go to nitro, and the nitro helped a lot, but I was taking it a lot.
When we talked on the phone, you said, I was taking nitroglycerin tablets like candy. How often were you taking those?
Well, I would say probably 5 to 6 times a week. And depending on how fast I could get rid of it, whether I took it more than once or if I had to wait 15 minutes and take it again, there was only maybe 3 or 4 times where I had to take it 3 times, and I was really panicked by then, but it did go away.
That would finally
after the 3rd one.
Wow. So, Dr. Gunasekaran, what do nitroglycerin tablets do? How do they help?
So think about the heart as a mechanical pump, right? Like any pump, this pump has also its own electricity, it has its own plumbing. And the plumbing of the heart is on the surface of the heart. Arteries which look like curly cues, and they're made of smooth muscle. So when you consume nitroglycerin, the smooth muscle in these arteries tend to relax, they dilate, they make the hose bigger, and you have better blood flow to your heart muscle. Better blood flow essentially means more oxygen to the heart muscle, and so the pain goes away. That's how nitroglycerin works.
When you hear Ann talk about how often she had to take those tablets, is that something that you hear often, or does that sound like, oh my gosh, this patient is in dire straits?
Yeah, an occasional nitroglycerin is expected in patients with coronary artery disease, but if you are taking it on a daily basis or weekly 5 or 6 times, or more or less the trajectory is important for us. Let's say a patient was just taking nitroglycerin once or twice a month, and now they're taking it 5 times a week or 5 times a day. That's a substantial progression. That's when it continues to bother us, because the trajectory is getting worse and the consumption of nitroglycerin increases. In her case, 5 nitroglycerins is a substantial amount within a week.
So, Anne, would these feel like attacks where suddenly you're in excruciating pain, or was it more of a situation where you'd wake up aching?
It wasn't excruciating at first. I mean, it would start kind of gradually, and I'd go, oh no, here it comes. And that's when I would start on the Tums, but sometimes it went away, but not very often. I had to resort to the nitro.
And your pain was so bad last year that you went to the emergency department at a different hospital. Then you ultimately came here to the health system. Where were you when you had that episode?
I was minding my own business in my own home, but yeah, it just hit me and I couldn't get it to go away. So I went to the local hospital and then they sent me to KU.
Okay, and Dr. Gunasekaran, is that the first time that you met Anne then?
No, not necessarily. I think she went to one of my partners, who was also a general cardiologist, Dr. Swati, and continued to be treated appropriately with medications. And then we sent out a department-wide communication saying, hey, we can help patients who have severe angina, and she's the one who actually spotted her condition and said, we're hitting a ceiling of medications, and my patient is continuing to have a substantial amount of chest pain. It is not responding to medications. This is not something we can fix mechanically by putting in a stent or do open heart surgery. So we really don't have options besides medicines, and we're hitting a ceiling there either due to side effects or just reach the maximum doses of these. So we really can't push any further. And that's when we look in terms of alternative therapies, and that's how I got involved, because Ankita and I are involved in this trial called COSIRA, or coronary sinus reducer, which has been out there in Europe, but it is being tested here in America. So that's why we identified her as a good candidate for this particular trial device, and we proceeded from there onwards.
And so that little device that we've been talking about that you can hold in your fingers, it's just a little mini hourglass.
Correct.
That is the trial. You put this in Anne. So Anne, you hear there's a trial, but it does require you going under a procedure and have something implanted into your chest. What were your first thoughts?
My first thoughts was, will it work? Of course, but then it was bad enough. I knew I had to do something.
You were ready to try anything?
More or less, yeah.
Yeah, that makes sense. So Ankita, this is where you come in. Anne says, sign me up. She's ready for the trial. I imagine it's not always that simple to get people to participate in these kinds of trials. What does that process typically look like?
So whenever we have a patient that come in and we think could be a potential, we have to run certain tests like stress test. We have to have a cath procedure done, so we have the angiogram images of what's going on.
A cath procedure?
Yes, so we get the angiogram images from that cath procedure, and or if we need the IFR and FFR measurements, or we need the CFR measurements, which are some of the volumes basically in the arteries, so that we can measure what kind of blockage, if any, is there.
Okay.
And if it's treatable. If it's treatable, then this trial doesn't work. So it has to be some conditions where we figure out, okay, this is not treatable.
What made you confident that Anne was such a great candidate?
So Anne had the classical signs, like she had angina almost every day. And then she was not able to function her daily work. Her quality of life was very much affected with this. And when she came in, we had most of her tests already done. So it didn't take us a lot of time for her to get in the study and for us to get her implanted with the device.
To get going on that. I want to actually share some of Anne's medical images that Dr. Gunasekaran shared with us, because you talked about how besides this device, it's medications, and she topped out on her medications. What does this image show? What are we looking at in Anne's body here?
So On the left side of the screen, we see this catheter, which is a long, slender device right by where you have the sternal sutures. That's the catheter we use to cannulate what's called a coronary sinus, which on the right side of the image, which is a black opacity, which you're seeing, kind of looks like a half moon. That is your coronary sinus. Now, what is a coronary sinus? Let's talk about the plumbing supply of the heart, right? So as I mentioned earlier, the oxygen to the heart muscle comes from what we call as coronary arteries, and these are on the surface of the heart. Oxygenated blood flows into these arteries, and then it divides into teeny tiny capillaries. These capillaries dive into your muscle, supply the oxygen to the muscle, which is basically fuel for the heart muscle. Once the heart muscles are finished extracting the oxygen, they dump this deoxygenated blood into small veins. And all of these small veins get together and form a larger vein in the back of the heart, and that's called the coronary sinus.
Okay.
And that half moon you're seeing on the right side of the screen is your coronary sinus. It's basically the outflow of the heart.
What are those little circles? Are those are stitches or sutures, you said?
The circles are from prior open heart surgery, which keep your sternum in place.
Got it.
The catheter, which is on the left side, comes from the jugular vein on the right side of your neck, and that goes into the right side of your heart. And at the junction between the right upper and the right lower chamber of the heart is where the coronary sinus comes off.
Got it. And then we have some more images. Some of them are moving as well. That will also illustrate what you're talking
Correct.
about. If we can. Oh, this is about how you're explaining how the coronary sinus reducer works.
Exactly.
Okay.
The catheter which I was referencing is what delivers this device into the coronary sinus, and it effectively creates a backstop in the outflow of the heart.
Okay.
Now, the goal of this device is not to completely block off the blood flow from the outflow of the heart, but rather cause enough of a reduction in terms of flow to a point where the blood stays in the heart for a longer period of time for the muscles to extract more oxygen. When they extract more oxygen, that's when symptoms tend to get better.
And then we have another video. I think we're going to take a look at another video and what's happening at this point.
So on the right side of the screen where you see that half moon, you see a little narrowing in there, like an hourglass-shaped black structure in there, because this device is hourglass-shaped when it's expanded. However, we have to compress this device so that it can easily navigate into the coronary sinus.
Okay.
And once you're in there, it's a balloon-based system, and that balloon is inflated for this device to get into that hourglass-shaped position inside the coronary sinus. And as I'm inflating the balloon, you're seeing this black structure within the coronary sinus right there.
And Kita, are you in the surgery room or the procedure room during these?
Yes.
And so what's your role during this as clinical research coordinator?
So we collect the time points when things were done, like when the wire was entered, when the device was deployed, what time, how was the patient feeling throughout the procedure, and their vitals throughout the procedure. So we do have to observe and take that. And also we have the device with ourselves, so we are the delivery person of the devices.
You hold the goods. Like the ring bearer coming down the aisle. And how was the recovery after the procedure?
Actually, it was pretty good. I thought I was going to go home that same day, but they informed me real quick that no, you weren't, that they needed to follow through. And it was really no big deal. And
is Anne out cold during that procedure? Sometimes patients are kept in a twilight stage. What about Anne?
This is not full anesthesia where you have a tube down your throat and you have a ventilator attached to you. This is what we call as moderate conscious sedation. Just like any heart cath, you get some fentanyl and Versed. Very mild sedation to a point where you're comfortable and pain-free, but at the same time, you're not too sleepy to a point where we need to put a tube down your throat. So we strike a balance between these two things.
And what do you remember about the procedure?
I remember a lot. They did tell me that if I was uncomfortable to let them know. And of course, I was doing just fine. And I know after it was over, I don't know if they took a stitch or what they did, but the doctor said, "Oh, I'm so sorry, but I didn't really feel it." I said, "Oh, it's okay." So we were fine.
You were able to chat. And Kita, is this typical?
Yeah.
So this is Dan's experience compared to other experiences. Is how it goes.
Most of the time we don't sedate patients fully because we need them to verbalize if they're not feeling well during the procedure, or if there's something out of the blue that they're experiencing, we want to troubleshoot. So we'd like to be in conversation with them. Some go to sleep right away. Some are just up and talking.
Up and chatty.
The important thing is to make sure they feel comfortable and pain-free.
Yeah. We already have some questions and some comments coming in. If you have anything you'd like us to read out loud on the program, or a question that you'd like us to ask our guests, send it to us right now on YouTube or Facebook or the All Things Heart email. The links on how you can connect with us in real time are right there on your screen. And as those questions come in, Anne, how has life changed for you since you got the device in January?
Well, I haven't had to use nitro nearly as much. There's been a time or two when I have, but that was more or less at the beginning.
Okay, so pretty quickly. And are you able to, when you wake up in the morning, do you feel a sense of freedom knowing that you're probably not going to have these painful episodes throughout the day? How has that changed your emotional state?
Oh, my emotions are definitely different, but it was really more in the evening and night when it seemed to bother me the most. But when I wake up in the morning, I look at my nitro, which I didn't let more than 2 inches away from me, and just kind of smirk and go on. So.
You roll your eyes at it. And Keita, who's eligible then for this, and are people still eligible to participate in this trial?
Yes, so the trial is still going on, and patients who have continued angina every day or every week, multiple episodes, and who have mostly exhausted all the medications they could be on and all the procedures that they could get are eligible for participating in this trial.
How many participants have you enrolled so far?
So far we have 17.
17, okay. And then Dr. Gunasekaran, what's the next step in the trial? What's the time frame?
So once the patient is in the trial, we not only look at how their symptoms improve over a 6 to 12 month time frame, we also look at objective measures, because pain for certain people may not be pain for me. You know, there's an element of subjectivity there. We also look at this from an objective standpoint. In other words, right before the patients get on the trial, some of them are put on a treadmill, and we see how far they could go before they have to stop due to chest pain, and see how their EKGs change because of lack of oxygen. And at 6 months after we give them the device and 12 months after we give them their device, we put them back on the treadmill or get a repeat stress test and see if they can go a longer distance on the treadmill. Is it taking them a lot longer to get chest pain than they did at the beginning of the trial? These are objective measures that we assess at the 6 month time frame and also the 12 month time frame. We also do in select patients stress testing up front as well as at the 6 month and the 12 month mark to see if the pattern of blockages that we had seen initially, have they improved over a period of time.
So Anne's due for a treadmill run.
Yes.
In a couple of months?
Pretty soon, yeah.
Anne, are you ready for that?
No. Yes, I really am, but you hear the word treadmill and you go, oh no. But
you're going to have to be ready. Let's get to some of our. Let's get to some of our community questions. And Anne, I do have a question, because you talked about, or Dr. Gunasekaran talked about some open heart surgery that Anne had. You had triple bypass before this. When was your triple bypass?
It was in 2004, and actually they hand scraped a couple more, and it was done by a Dr. Gandhi in Topeka.
Okay.
And I was in the operating room a lot longer than they thought, because they were hand scraping some, but it was an experience.
And did this precede your bouts of angina?
Oh my, yeah. Okay. Yeah. I mean, even after my open heart, I didn't have the angina problem until maybe 2 or 3 years ago.
Okay, okay. So you've had your fair share of heart issues. We have a question coming in from Kathy. Kathy wants to know is triple bypass related to angina, or are those two separate things?
Angina by itself is a symptom. And the symptom of feeling chest pain, pressure, is what we call as angina. It's a symptom from lack of oxygen to your heart muscle. And that, more commonly than not, is due to a blockage in the plumbing supply or the coronary arteries.
So it's a symptom of those blockages?
That's exactly right.
Okay.
The blockages impede the blood flow, and the lack of blood flow means lack of oxygen. Lack of oxygen means angina. And to alleviate these blockages, there's three things we can do. One is put a stent in those blockages, or perform bypass surgery so we can restore the blood flow to the muscle, or treat them with medicines. And the thing is, there are certain patients who are candidates for a lot of these things. Not all of these things work in the long term. Sometimes bypasses may fail. For the most part, they do good. Stents may fail in a certain proportion of cases, which means we're back to square one. And there's a small subset of patients where we cannot mechanically relieve the blockage. For them, medicines are the only way to get across this particular symptom. And the problem with these medications is, for one, they have to be at a certain dose, and those doses mean side effects like low blood pressures, low heart rates, fatigue, tiredness. So we go to solve a problem, but then we end up creating another problem because of high doses of these medications. So patients don't tolerate a certain dose. And if they can't get there, their angina still persists, and it becomes a day-to-day problem which affects their day-to-day lifestyle.
Right, and that just affects poor quality of life, leads to, I've heard so many doctors say, poor health.
That's exactly right.
Denise wants to know, how do you get the device into the chest? Do you go through neck, leg? How do you do that? Ankita, do you want to take this? Or you want Dr. Gunasekaran?
Yeah,
okay.
I'll have
So how do you get the device into Anne?
So the coronary sinus can be cannulated or accessed through the right upper chamber of the heart.
Okay.
And how do we, the easiest way to get to the right upper chamber of the heart is through your jugular vein, like right here. So we use an ultrasound catheter to kind of find that jugular vein, insert a needle in a small tube, which is a couple of millimeters, and through this tube we insert a wire. Under X-ray we find the coronary sinus, and we track a catheter into the coronary sinus. And then through that tube, we take this device, which is a balloon-based system. We inject some dye into it. Once we like the position, we blow up the balloon. And the design of this system is in such a way that once we blow up that balloon, this device takes its actual hourglass position, and then we deflate the balloon and pull it out.
I have a question from Jim. Jim wants to know, Ankita, I'll give this to you. Is it more difficult to get people to enroll in trials that involve a medical procedure rather than a study? So for someone to enroll in a trial where they're having a procedure done to them, is that more difficult to recruit?
Yes, because we need them to match the eligibility criteria that are there, and they are very strict. We cannot deviate from those criteria.
What about the willingness of participants? I think Jim was asking, are people more worried about having a procedure rather than testing a medication? Does that play into it?
Yes, it's both risky. Some people, because testing a procedure or a device is just one day. You are put in and then you live your life. For the drugs, it's like they have to have commitment to do that every day. They have to take that drug every day. So it's both ways. The risk is there both ways. But yes, to get a patient on a procedure or a device trial is much more difficult because the criteria are very strict.
Lisa wants to know, how long can the device last in the body, and will it ever need to be replaced?
No, it stays in there for life. It does not require any maintenance, and tissue kind of grows into this device and becomes part of your coronary sinus.
Becca has a question about angina. She wants to know, is it genetic?
Coronary disease by itself tends to have a genetic component, because if you have high cholesterol in your family and bad genes because your enzymes can metabolize cholesterol, that can lead to blockages. Blockages can lead to angina. So you indirectly have a genetic component, but again, angina is a symptom. Okay. It's the underlying process which can be genetic.
Jeremy Yenser, one of our viewers, wants to know, does the device work better because of a specific reason for the angina? For example, if there's a blockage, or if the issue is because the artery is just really bad at dilating. So does the device work better because of a specific reason?
That is an excellent question, because most people have angina from actual blockages. There is also a small subset of patients who have angina because the artery is constricted. and they
Okay.
go into spasm. We call that microvascular angina. So we are cognizant of the fact that there's two kinds of patients here who have the same symptom. So we have a trial which is designed not only to address people with blockages and resultant angina, we also have a sub-study within this trial which specifically looks at two kinds of patients. Ones who don't have a blockage but still have angina, and also those who cannot go on a treadmill, because some patients just have an orthopedic issue, they just can't go on a treadmill. So we are studying both of these conditions actively, and we will know the results of these in 6 to 12 months.
Question from, oh, this is a good one. Erica has a question about blind studies. So in studies, you often hear about some people getting a medication and some people getting a placebo, and the patients don't know. How do you do that with a procedure? Does that happen with a procedure?
Yes.
What does that look like?
This trial has a randomized part where we prep the patient, we do everything like as we will do when the patient is getting implanted, and then we'll randomize on the spot. Like once the patient is prepared and everything is ready to go, we randomize. And if the patient gets the device, we continue with the procedure. If the patient doesn't get the device, also we continue the procedure.
But it's like a fake procedure?
Yes, it's like a sham procedure.
Wait, so they're in a twilight and they're imagining being poked and
Yes.
getting things put in them?
You actually get the cannulation into your vein.
Okay.
We go into
do
the
everything.
coronary sinus, you take the picture, you just don't implant.
And so how is it that Anne knows she has it then?
So Anne was in that arm where we had the single arm, we call it the single arm.
Okay.
So we get the device to her in all the patients, like whoever, like Dr. Gunn talked about, who cannot go on the treadmill or
Got
do not
it.
have a blockage. So we give the device to them. But there is a randomized group as well where
They're walking around and they don't
Yeah.
know if they have the device or not?
Yeah.
Correct.
And they just know they went out or went under, but they don't know if they got it or not.
Yes.
It's at the end of 12
So
months that we
interesting.
disclose to the patient
Okay.
and say, yes, you had a device versus no, you didn't have the device, because we don't want this bias to creep in the next 6 to 12 months. Because placebo is powerful too.
Right.
When people think that they had something done, they tend to feel better.
So that's so interesting. So the placebo effect has always been fascinating, because if it can work that powerfully, why can't we channel that? This is a much broader discussion for,
Right.
it's like a late night discussion, but it's fascinating to me that people with the placebo effect could feel.
It is very much a possibility, and that's why this trial is unique in a way, because we have designed an arm which takes into account a sham procedure. We just don't tell the patients until 12 months, but at the end of 12 months, we tell them, you didn't have the device,
Yeah.
you still continue to have angina, and that's when the trial gives you an option to implant the device
To
at the
get it,
end of
yes.
12 months if
Okay.
you still have a substantial amount of angina. So it's
Super
not like you go the entire duration of the study and you never got the device.
Right.
You have the option of getting it at the end of 12 months if you just didn't get it up front.
Okay.
And there's also patients who can't go on a treadmill or belong to a certain subset of angina without blockages, where we don't randomize them by a toss of the coin. We actually give them the device and see how, and we maintain them in a registry and we study them long term.
And that's Anne. As we wrap up this discussion, I'd love to get some takeaways from our guests. Anne, I want to start with you. What do you want to tell people who are watching this right now and they're on the fence about being involved in a clinical trial?
A clinical trial is hard because you don't know for sure if you get it or you don't. I was lucky, I knew that I got it, but it is very difficult to be on that fence. But I do think that my end result was definitely worth it, because I definitely feel better. I don't have to use nitro all the time, and I can tell that without the angina, it just gives you a better feeling, better
Sure.
quality.
I got to say, Anne's awesome. When I was talking on the phone with her, she was teasing me. I heard her teasing Cliff, who's our photojournalist that's in Atchison with her, asking, "Where did you bring my breakfast? I want you to bring me my breakfast." I mean, she's back. Anne is on fire. And Kita, what would you like to say to people who are considering a clinical trial or in the same position Anne was in maybe 2 years ago?
I'll say if you're considering it, reach out. The best way to answer any questions is if you ask it directly to us. So reach out to Dr. Gunn or reach out to us so that we can answer all your questions.
Do they just call the health system and ask to?
Yeah, they can call the
Okay,
yeah, they can call the health system and ask for research department from there onwards. And then I'll say to those patients, if you're really suffering with angina, do reach out, explore this as an option, because right now this is the only way to get this device.
Is this clinical trial?
Yeah, before the FDA approves, this is the only way we can.
And that, as is often the case
Yes.
in these trials.
Yeah.
Dr. Gunasekaran, what do you hope for the future of this treatment, and what do you want our viewers to know?
I think if you have been told that you don't have an option of a bypass or stents, or you don't have an option beyond a certain set of medications, this is something which can be fixed, potentially fixed. Be part of something which can help a lot of other people too. This might not just help you by participation in the trial. This can help 11 million people who have angina and have been told there's potentially no options for them to feel better. So that is the one thing I would say, that we keep an open mind. The second thing is, with clinical trials, often there's a perception that, am I going to be a guinea pig for some kind of experiment, right? The trials which we conduct, let's say we have two arms. We are not allowed to conduct a trial if there is no equipoise between these two arms. By equipoise, I mean that there is a reasonable chance of benefit being in both of these arms of the clinical trial. So we take that very seriously and make sure that you have a very well-informed process about these trials, and then we let you choose to see if you can be part of a new trial or procedure which can help you and millions of others in the process.
These can really change the research and change medical advancements.
Absolutely.
Anne, thank you for joining us and sharing your journey. And Ankita and Dr. Gunasekaran, thank you for taking the time out of your day, treating patients, to join us as well. And to our viewers, thanks for joining the conversation. Coming up tomorrow morning, we hear directly from a patient on the pain of living with sickle cell disease. We'll share the treatment that changed his life. That's tomorrow at 8 a.m.